Fever. What does a fever do to kids who already have epilepsy? Lowers the seizure threshold. Yep. What is your dose of ibuprofen?
10 minutes.
5 to 10. Yep. What's your dose of acetaminophen? 10 to 15. How old can you give acetaminophen?
2 months.
How old can you give ibuprofen?
6 months.
Keep that in your mind. Okay. An infant is less than 90 days old. You are going to add acyclovir as empiric treatment for a toxic child with what? HSV. That will be on your boards. It's just is every single time. Okay, fever plus a petechial rash diffusely in a child equals. And your empiric treatment for Neisseria meningitis. Ceftriaxone and vape. Yep, perfect. Ceftriaxone and vape is your empiric treatment for that. Who's at higher risk of a UTI? Girls and uncircumcised males. How old?
1.
Up to a year. Yep. A defect in complement makes you think Neisseria meningitis. Do you need to do a routine CT scan before you LP a child?
No.
Okay, so we are going to add on infectious disease from kind of where we picked up yesterday. So keeping in mind some of the fever conversations that we were having yesterday, we're going to kind of look at some of those classic things. Some of these things we see a lot. Some of these things we don't see that much, but you see them on the boards because they're so classic. So kind of a secondary review from infectious disease. As a reminder for this block, there is a lot of review from your ologies that you've had. Okay, so when we go over some of the things that you've heard, I'm not going to test you on the disease itself as much as how it relates to a child. Why did we talk about it in here specific compared to the rest of your ologies? Okay, so keep that in mind, thinking there's a lot of these things. Other thing that I wanted to bring up, just kind of interesting, is this is real life stuff. So we're talking about measles today as one of the infections, and this was yesterday's news. So the first thing in the morning when I wake up, AAP, American Academy of Pediatrics, is saying, hey, our top story today is that measles is set to break a record from 1991. Right? So these are real-time events that are happening to real-time providers. You will be very shortly a part of that. So just as a reminder, these are real patients coming up. So the first thing we need to start with is talking about rashes. So yesterday we said kids get fevers in every day that ends in Y, and just because it's a day that ends in Y, the same for rashes. I need you to think of a child's skin as part of their immune system. So it's a little different from us. If you came to me with a fever and a rash as an adult, I would be like, you're probably dying. You should go see someone. BAMC's right down the street. Let's go now. A child with a fever and a rash, it's a yawn because that's every single day because that is their immune system happening. So you're going to see a lot of kids on your rotation and in your urgent care, ER world, primary care world, who will come in and the parents will say, I'm here because they have a skin rash. And your diagnosis on the outside, as they leave, will be that they have an infectious cutaneous exanthem. You're like, isn't that just a synonym for a skin rash? Yes, yes, it is. But you have said it in provider terms. So you have diagnosis. If there's exanthems, that's on the skin, where are enanthems? Inside. What does inside mean? On what type of surfaces? Mucosal surfaces. So when you see that, you saw something on mucosal surfaces, you could say infectious cutaneous enanthems as well. So something to think about. This will be a common diagnosis that you see. Now the way that this matters is because there was a classic numbering system, so back to our history, that before we had PCR, before we had numerous ways to test for these different types of rashes, they were so classically defined that we would just say, oh, they have third disease, or second disease, first disease. What's this one that we still use now? Fifth disease. And why is that one? Well, because the rest of them we either, well, I guess except for rhodiola, but for for most of the other ones, we've either had antibiotics or we've had vaccines that have decreased those so much so that we really functionally don't even see them very much anymore. Except it's on the rise, so we're going to be seeing measles together shortly. Okay. I'm not going to try to trick you and say third disease on a test question, except for fifth disease would be the only one because we still use that one day to day. But helpful to know this historical naming system. So let's start with measles. So rubeola is your other name. I'm not going to use rubeola on a test. However, it is fair fodder for the PANTS. So I have seen PANTS prep questions and PANTS questions that use rubeola instead of measles. So just to be aware, I won't do that on this exam. Very, very contagious. So when you talk about how contagious, we're talking herd immunity needs to be above 95% to maintain this. Why is this? Well, it's actually a pretty stable virus, so the virus doesn't mutate a whole lot, like some of the common colds, some of your other viruses do. So such a stable virus allows it to transmit and to spread very, very easily. So herd immunity, very important for this one particularly. If you watch old shows, this used to be everywhere. So one of the classic examples, there was a Brady Bunch episode where the little blonde one gets sent home and she's like, I got the measles, right? Because everyone used to get it by the time they were 15 years old. So it was pretty standard, obviously not anymore. When I first got to IPAT, some of the numbers up here had 2019 with a couple of hundred cases. 2024 had a couple of hundred cases. By right now, this summer, we're at almost 2,300 cases, and we're on track to at just a straight curve up. So this is on the rise. We'll probably be seeing this all together a little bit more. This virus, found from your respiratory tract. Not only is it a stable virus, overall it's a pretty light virus. So when there is a cough, a sneeze, those particles can hang in the air up to an hour. So if you think about one of the first outbreaks that we had kind of in this resurgence was at Disneyland. So think, you have somebody who coughs or sneezes and everyone's standing in line just walking through that. Walking through and getting exposed to that. So that's how it can certainly very easily be spread to that. Because it's such a stable virus also though, it means that the antibodies are highly protective and they are pretty stable as well. So now you have mom who can give transplacental antibodies. Those antibodies are actually pretty stable and they hang on for about a year, which is really convenient because that's right when we give that vaccine. So about a year of protection from that. What else is about that vaccine particularly that's interesting? It's your first live injected vaccine that they get, correct. 4 phases, I need you to know these phases, so star, highlight, underline your 4 phases that you have because they are very particular for measles. So you have this incubation period, your prodromal, your exanthemus, and then your recovery period. Like any other virus, you're going to be highly contagious a couple of days before your symptoms even start, which goes to continuing to pass this around to everybody. Okay, so this is the one I need you to know, these 4 phases of this, okay? For most of these classic numbered rashes, but really any of them, most of these have very long incubation periods. That can be helpful in some ways because that can give us a time to intervene if we have somebody who's immunocompromised, if there is a immunoglobulin that we can give, super helpful. But it can also mean that when you're doing contact tracing, when you're trying to figure out what somebody did, where they were, you're having to go back 2 weeks ago. So if I asked any of you, what were you doing last Tuesday morning 2 weeks ago? Well, you guys actually might know. You're like, you were in this room, same room, right? Most people, you're thinking, what did you do 2 weeks ago and any time in that period? They aren't going to have a good indication of where they were, what they were doing exactly. If you ask me what I ate for breakfast this morning, I probably might not even know. For most people, that's what's going to be really difficult for some of these measles particularly. Then you have your prodromal period. So now you've had this long incubation period, then the kiddos spike with a relatively high fever. So while we don't have low grade, high grade fevers, This one relatively spikes and stays high in your 103, 104, 105 type ranges. In your classic 3 C's, so your fancy word for runny nose, cough, coryza, conjunctivitis, and with your Koplik spots. Those are your classic ones. If you see that picture together, if ever a question has coryza, they're not just trying to be fancy, they're trying to tell you this is measles. So that's that type of question. Then your rash comes on. So this is that 2-week period. So after exposure, now you have this 2-week period. And this is very particular. So they've had this high fever, now the rash starts. It is the only rash that's going to start in that hairline and work its way down. Interesting to me, maybe not to anyone else, but interesting to me, usually the severity of the disease goes along with how far down the rash goes. So if the rash only goes mid-chest, a more mild case than if it spreads all the way down. So kind of an interesting correlation there with that rash. It then will fade in that same pattern, which is a really weird way to fade as well, very, very specific, and kind of turn a brownish, lighter color, and then sometimes deswamping. Right? So I need you to be aware of these 4 periods, the particular things that you're going to see, the way that the rash spreads, and then to be able to determine which way. So for all of these, how does the rash spread? Does it itch? Does it desquamate? What does it leave out? What does it include? So as we kind of go along, that's going to help you distinguish these things on test questions. When we look at Koplik spots, so this is pathognomonic of this. What does pathognomonic mean? Yeah, it means it can be nothing else. If you see that, it has to be this. So if you see Koplik spots, which I never have, relatively hard to find, it is right adjacent to typically the lower molars. It's a small area of necrosis inside that mucosal surface. Very, very shortly present, so only 12 to 24 hours. If you see it, it can be nothing else. So if you're looking at things and they're giving you a picture of a mouth, of a little grayish area, a little pearly area, can we have a little black or kind of white dot on that area, a finite little area of necrosis, it can be nothing else besides measles. So that's your Koplik spots that you have. The rash is sometimes described as a morbilliform rash. So again, starting up at that hairline, coming down diffusely, can be the whole body, can stop somewhere. An exanthem. Your diagnosis. So yep, you're at the beginning of it is going to look like everything else. So that's not very helpful on a test question. In the boards or here, where I give you there's fever, rash, runny nose, cough. You're like, yeah, that's every single one of them. You're gonna have to pick out what's distinguishing. Usually they'll give you this is an unvaccinated child, this is a child who recently moved, immigrant, adoptee, something like that. Your PCR and your RT-PCR will be how you will diagnose this. Otherwise, your IgM, what's the difference between IgM and IgG antibodies? So which ones are right now? Yeah. So right now, current infection, I will never forget how I learned it. It was there, right meow. Right meow. And it's a really, really big antibody, so it doesn't cross the placenta as well as your smaller IgG that does. The other interesting thing about this one, if you see this, please report it to the State Department. So I actually have seen that be something that will come up, is this reportable or not? So measles is reportable right now, which is actually why we have such good numbers to say exactly what the cases are. So today we are at 2,259 cases for the year 2026. So that's where we are. It will continue to go up as the summer happens. Now the treatment. I think this is probably, other than the way that the rash spreads, this is the most common way that I've seen this tested for your pants, is looking at what do you do for treatment. So one of the most common misconceptions is that we can do vitamin A for prevention. So vitamin A does nothing for prevention. It's going to help with treatment. Kind of interesting to me, because you guys know how much I like history, that this was a project that UNICEF and the WHO were doing together, where they were going out, they were doing some vaccines, and they were also had a campaign against blindness. So they had gone out and been doing vitamin A to prevent blindness. When they did that, they realized that that really correlated with the severity of measles. And so it was a total accident how they realized that this helps. So complete accident, helpful for treatment of this. It helps make it less severe, helps with less complications on the backside. But what happens is a lot of times people will do high dose vitamin A as a prevention, and then they will end up with a fat soluble vitamin overdose. So not great. Don't use it ever as prevention. Use it as your treatment. A couple of those really rare complications are going to be CNS complications. These classic exanthems typically have a severe and a late CNS complication. So these ones are, I'm not going to waste a test question asking you about subacute sclerosing panencephalitis. If you see it though someday, call me, because you're like the world's greatest diagnostician, and I want to shake your hand and see that patient. But if that happens, maybe we'll start seeing more of that as we go. Your other things are going to be complications that have URI-like complications. Otitis medias, potential pneumonias, kind of those heme things that we see as complications of URIs. Your prevention, right, we're going to vaccinate. Your live vaccine, you already got that one. The first one we give at that year mark. I'm not going to test you exactly on timing like that. The second one at the 4 to 6 year mark. The interesting thing about that you do need to be aware of is that at 12 months, we give the MMR vaccine and varicella. We do not combine them. When they are combined, the increased risk of febrile seizures is high. We do not combine for the 12-month. We don't see that at the 4 year. So 4 year, give that combined MMRV. Immunocompromised, never going to get live vaccines. Pregnant, never going to get live vaccines. This one does have that immunoglobulin. We have a long incubation period, so we are able to give that to vulnerable or immunocompromised patients if they need that because of that long incubation period. Those are available. So how does the rash spread? Not just head down, particularly where? Yes, hairline. How does it recede? Same way. Does it itch? No. Does it desquamate? Yes. Treatment? Vitamin A. Prevention? Vaccines. Oh, rubella. One of my favorites. I think rubella is awesome. I mean, it's not awesome, but it's a really fascinating virus. What I need you to think of this, if you're trying to study this, it's measles light. So everything that measles is, rubella is that a little less. Okay? What's interesting about rubella and why it has been so concentrated on as something that we want to prevent is that there are some viruses, there are some infections that are really bad for kids. There's measles, there are some complications, highly contagious, okay. Rubella is not a problem for most normal, healthy, happy kids. Not a problem at all. It's a problem for adults, and it's a problem for fetuses. Feti? Those in utero. It's a problem for them. Fetuses? So those two groups. And so we're vaccinating to prevent it for those two groups, or as opposed to your normal, healthy, happy kiddo. I'll talk about why. So mild exanthemus, for most adults get the severe complications. It's the congenital rubella syndrome that we are trying to prevent. So that is where you get the big deal. This antibody, not quite as stable of a virus. So while it's got good stability, not as much. So only about 6 months of coverage compared to 12. And it's part of our first trimester OB screening. So we want to know, is mom immune to this or not? Spreads from the respiratory into your lymph system, into your lymph nodes. Again, very highly contagious. You're contagious before and then those first few days of the rash. The big thing is, and I want you to highlight, underline, is this is a congenital risk in your first trimester. So that is where I see that people get off, is when they don't know which trimester. So they'll say, mom's 35 weeks pregnant, is this a problem? And you're like, oh, I know it has something to do with congenital. I should pick that one. Don't pick that one. It's first trimester, really in the first 16 weeks. So a little tiny bit in there, but first trimester. So postnatal, this is measles light. You can literally write measles light on there. They're similar to URIs, long incubation period. The one distinguishing feature, if they give this to you, or if you see this on exam, is that they have suboccipital and post-auricular nodes. That's pretty rare. What else has post-auricular nodes and post-cervical nodes compared to anterior? So everything has anterior. Every single URI has anterior. A few things have these posterior. Mono, what viruses are those? Epstein-Barr and CMV, correct. So those have your posterior cervical chain. This is another one that's got some posterior auricular, and your suboccipital. That's a rare place for those to be. So if you're coming in with a kiddo who's sick, got posterior auricular, posterior nodes, you're thinking, is this a mono or is this a rubella? The distinguishing thing there is on a test question, and really in real life, are they vaccinated, are they not? So if they give you an unvaccinated child with post-auricular nodes, you're like, oh, that's got to be rubella. They're giving you those two things. This rash still starts on the head, but it's really more on the face. It's not the hairline. Works its way down, but otherwise it does the same exact thing. Less prominent, and some do not even have the rash. This one does have 4 Scheimer spots instead of your Koplik spots, but they are not pathognomonic. So if you see these, this does not mean that they have rubella. It increases your likelihood that it is, but not pathognomonic. What other things have a palatal petechiae hemorrhage? Like the most common thing that you see in the mouth. Strep pharyngitis. Yeah, strep pharyngitis is going to have a palatal petechiae sometimes as well. So with that, then you're like, well, is this strep? Is this rubella? And they're going to tell you this is an unvaccinated child. Teens, and the older you are, more symptomatic. That makes sense for most of these. So again, measles light, showing you 4 Scheimer spots. If I were just to look at that rash, I would have no way to distinguish that between that and measles. To me, that looks the exact same. You can't even see, he's got like man bangs or little boy bangs. So you can't even see where this is starting from. So not as helpful to me, but if they're showing you different parts of the mouth, they're trying to point that it is rubella versus your measles. Another IgM, right meow, right your RT-PCR. Another one that's reportable to the health department. Same exact thing as measles that we have. Here is where the problem is. Now, your congenital rubella syndrome. So, did you guys learn about blueberry baby? What is causing that blueberry baby? What are all those spots? Not petechia.
Shapiro?
Not Shapiro. It's very interesting. It's the only thing that does this. It stops, so this virus will stop different areas of mitosis. One of the places that it will stop doing that is in your bone marrow. So a baby's compensatory response is to have extramedullary hematopoiesis. So all of those little areas are places where you have extramedullary hematopoiesis making blood cells. That's what's causing the blueberry baby. So we say that it's a rash. You're like, well, not really, but it looks like a rash. So that's what the blueberry part of blueberry baby is. What will happen with that, because it inhibits some of the mitosis of different places, then you have issues with things that are forming. So one of the things that has trouble forming is your temporal bone. Your temporal bone does not form correctly. You end up with sensory neural hearing loss as a baby. You end up with deafness. You end up unable to make the full compartment of the heart. You end up with a patent ductus arteriosus that does not close. So PDA, circle and highlight and star that one. PDA with congenital rubella are ones that you should pair up in your mind. The problem is it doesn't just inhibit mitosis. There's other parts of that where it will start to exacerbate mitosis. So this will happen in the eyes. So the lens will start to become cloudy. So you come up with congenital cataracts. What is that sign when you look in the eyes? Leukocoria, correct. If you see leukocoria, who are you calling? Ophthalmologist. Yep, because until proven otherwise, leukocoria in a newborn is retinoblastoma, correct. This one, they will shed this virus. If they have this as a newborn, they will continue to shed this virus for almost a year after birth. So a long time of shedding this virus. The way that I've seen every single one of these questions is there is a daycare worker. So she's a daycare worker and she works with all these kids and she finds out that she's pregnant. That's the start of every single one of these questions. So it's asking you to realize, oh, she's around kids who are too young to be vaccinated. Potentially they have rubella. She's pregnant in her first trimester. She's giving it to the baby. That's how they're trying to get you to correlate those in your mind. So as you're studying. Again, no specific treatment, supportive care. You want to vaccinate, it's part of your MMR one. You could theoretically give your post-exposure prophylaxis, but since most of it's measles-like, we're really just trying to prevent. And the problem is we're trying to prevent it in the exact population who needs this. So now your pregnant population is unable to get this live vaccine. So that's why ideally, before somebody is trying to get pregnant, and older teenage girls, we're making sure, have you had your vaccine? Are you on a prenatal vitamin? What is it that we want in the prenatal vitamin? Folic acid. What's your dose? 400 what? Micro. Yep. Okay, mumps. Mumps is weird to me. It's actually not in your textbook at all. So it's in our big textbook, but it's really weird to be like, we're going to talk about MR. Right? There's that second mumps, so have to throw it in there for why you're talking about mumps. Where does mumps affect? Your parotid glands, okay? Where else does mumps affect? Testes, where else does it affect? What do the testicles and the parotid glands have in common? They secrete things. Where else secretes things? Huh? Pancreas, yep. Where else? What if you're a female? Ovaries, correct. Yep. So anywhere that's going to secrete things is where mumps can attack. So particularly in those salivary glands, but you see that otherwise. So yes, the vaccinated population, this is one that kind of has some breakthrough. So even if they are vaccinated, not as stable of a virus can have this breakthrough. It's very painful, and this is people do not want to drink. So they will often end up in kind of that downward spiral as a child as well. Same thing, long incubation, long time where they are contagious, most infectious before, and those first few days, recommended to isolate. Okay, so salivary glands, you guys got it, pancreas, testes, and in the ovaries as well, you can do that. Pretty much going to be more of a problem after puberty. So if you have a pre-pubertal child, not as big of a deal as after puberty in these teenagers. And that's who actually ends up usually getting this. So something to be aware of, something to look at. The virus itself causes a localized necrosis and a localized ischemia, which number one causes the pain, and number two causes your dysfunction. So it's that necrosis that you really can't do anything about. It's going to be a difficult issue. So biggest thing you're doing for treatment is hydration and pain control, and then making sure, are they fertile after? This is the picture from the book is the top one. I don't love it because if I didn't know what this child looked like at baseline, I might just think, oh, pudgy little one. Right? It might not be something that completely stands out. The picture on the bottom is a teenager with this. And so if you have a picture of this is what they look like normally, and now this is what they look like, that's a lot more helpful diagnostically. So a lot of times if somebody comes in and they're like, look at this, and you're like looking at them and you're like, I don't see this. Ask for a picture from what was it like before? And that can sometimes be really helpful diagnostically. So this would be an example of how significant the parotid glands will swell. Your history and your physical exam can make your diagnosis. You can make this a clinical diagnosis, certainly if they have pain and ear pain. Amylase can be helpful. They're not diagnostic, but can be helpful. Other things, a lot of things can cause keratitis, so you can have an autoimmune issue, can have tumors there. Not as common. Again, supportive treatment, pain control, hydration. No antivirals are going to help. Really good prognosis unless you're post-pubertal and you have this orchitis. One of the classes a couple ago asked about females, and so looked up the data. There is some oophooritis, and that can cause some infertility in women, but it's significantly less, seen most in the Middle East, because that's where you see a lot of mumps still. So again, vaccination, our last component of our MMR. Fifth disease, one of my favorites. So this one, I do want you to know all three names, because you will see all three of these tested. So sometimes they will use Fifth disease, sometimes they will use erythema infectiosum, and sometimes they will use what? Parvovirus, correct. So all three names, please be familiar with all three of these when you're studying them. What do you look and see about this kid at the bottom? He's pretty happy, right? How would you describe this kid? Toxic or non-toxic? Non-toxic. So this is what's telling you about this for most kids. Most kids are pretty darn happy with this. So parvovirus, B19, pretty healthy. The problem is if you have an underlying red blood cell disorder, because that's where this virus goes and attacks. So if you got parvovirus and your red blood cell factory is shut down for a week to 10 days, what happens? Nothing, right? You're just fine. Your body can make up for that difference of a week to 10 days. What happens if you have sickle cell, spherocytosis, thalassemias, things that are constantly getting taken out of circulation, and you don't have a factory to make more for a week to 10 days? Anemia? Like how bad? Like significant. Like really significant anemia. Okay? So those, if you get a question that tells you that this child has sickle cell, this child has spherocytosis, thalassemia, anything that is red blood cell that is going to be taken out of circulation sooner than normal, they're trying to ask you about parvo. Okay, so anything to look for that. The problem is, again, not for the normal, healthy, happy children. The problem is not for adults. This time the problem is your kids with those red blood cell disorders and the fetus again. Okay? This time the fetus is the second trimester. Why? What's happening? In the second trimester, all the organs have been formed, but you have this no flow equals no growth. Okay, so if you have a week of your 40-week gestation where you have absolutely no new red blood cells, that is not compatible with life, and you end up with a fetal hydrops. Usually in the spring, if they show you anything about puppies, they're trying to ask you about parvo as well. Long incubation period, again, that non-specific for most kids. The rash is the 3 stages. So Fifth disease has 3 names. The rash has 3 parts. I need you to put that, I know it's Fifth disease, but I need you to put the 3s together. 3 names, 3 parts of the rash. Those 3 are going to go together. For the adults, you feel a little bad. It's nothing to write home about. They're not going to ask you about adults because they look like everything else. Okay? So what's the first stage of that rash look like? Slap cheek rash. What does that mean? Bright red cheeks. Where does it spare? The mouth. It has everything around the mouth. Okay? Look at that kid. How do you describe that kid? He's smiling, right? So they're still pretty happy. Okay? So that's what I want you to take away. They're going to show you pictures of kids, and if the kid is smiling, don't pick hospitalize and admit. Don't do that, right? Because they're trying to show you that these kids are healthy and happy, and something is temporary. Okay? So that slapped cheek reaction spares the mouth, spares those nasolabial folds. What else do you think when you see something that looks like this? Lupus. Where does lupus also affect again? The kidneys. Good. Second one, the rash then spreads down into the trunk. It is symmetric and kind of this just erythromatic red rash that's on this kiddo's trunk. So they had the cheeks. That's usually when they will come in, because they will be febrile and have their cheeks. And be like, I know exactly what this is. This is parvo. questions that I'm looking for, do you have any red blood cell issues? So second stage, kid's still pretty happy. We're doing good. Things are still good. As it fades, the middle of the rash starts to clear. So you have this centralized clearing in these rash. It becomes lacy. So when they say lacy or reticulated, the way that they're trying to look is like one of those like lace little doilies. So kind of just has this kind of lacy pattern that's all connected and all hooked up together. And if you laid that down on a kid, it would kind of look like that. Some of those central clearing. This one lasts a long time. So one of the things to talk to families about is this is going to hang around for a while. Most people are expecting a couple of days, 3-4 days. This rash is going to leave my kid. You're not telling them, hey, this could be several weeks. They're going to be back in there every week being like, there's still a rash. There's still a rash. It's still there. How long is this going to be there? You tell them up front, this rash hangs on for a long time. It's going to get itchy, but it's not going to peel away. It's not going to desquamate. Then there will not come in as much thinking that something is abnormal. Where does it get particularly itchy? Over places where there's a lot of friction. So this would be the kid that would come in and say, I really don't want to wear elastic pants, or I really don't like the way my socks feel right now. I really don't want things around my neck, because that it gets particularly itchy where the rash is on that. This is then the complications is your aplastic crisis. Aplastic meaning what? Yeah, nothing. So it's not making anything. It's going to shut the factory down. Aplastic. So you got nothing. So again, totally fine if you're a normal, healthy, happy individual. You can last for a week. Not okay if you see any of those red blood cell issues. I want you guys to be the first class that doesn't miss this question. Okay? That's why I'm telling you this. You see your red blood cell issue, think parvo. Think what's this going to cause? Profound anemia, so they will come in and they will look sick. So you've been this whole time seeing kids with parvo that are smiling and that are like, I feel great. This is the kid that doesn't look great. So when you're thinking, wait, I associated parvo with these kids feel fine, these kids come in sassy. Right? They come in and they are not doing well. Significant pallor, significant alterations in their vital signs. They do not do well. When you test their labs, makes sense that their CBC is going to be low, their hemoglobin is going to be low. But if someone's hemoglobin is low, what is normally their reticulocyte count? High, right? How high? What percent? Way above what would be normal. What's normal reticulocytes? Yeah, and even kids, you can see sometimes that like 1 to 5 being normal. So these kids, you would expect to see reticulocytes like off the charts. These ones, you got nothing. So low reticulocyte, low hemoglobin, setting of a red blood cell disease, you have a significant aplastic crisis from parvovirus. Again, if they are in a fetus then, you don't have 7 to 10 days. Just not at all. Just not going to be compatible in that second trimester. So again, if some question has a 35-week pregnant woman, well, we already passed the significant time. So in that first trimester, we're still forming organs, not as big of a deal. Second trimester is where parvo is. And that's where they get the high drops. So biggest risk to pregnant women, rubella, parvo. The two I want you to take away from today. Your diagnosis is history and physical, so you don't need to be doing labs. If you are going anywhere in a DHA clinic or really on the outside and you are going to use your electron microscopy to diagnose this, call me because I really want to know what clinic you're at and see an electron microscopy. Otherwise, most of the time, keeping those kiddos hydrated. Antipyretics, what are your options? Ibuprofen, acetaminophen, correct. And then transfuse those who have this transient aplastic crisis. So they are continuing to be very, very sick. IVIG can be very helpful. So IVIG is wild. We'll talk about that when we get into hemo, but just a wild medication. And I'm like, how did we decide that we were going to do this? But pretty cool. Roseola, our sixth disease. Roseola is a particular favorite of mine. I love roseola because you can look, as a diagnostician, as a clinician, you can look like an absolute wizard. And that is what I hope for all of you. You can look like you are just absolutely brilliant, which you are. If nobody's told you that you are brilliant today, please remember that. You are brilliant. Okay, so this one is the fever that rashes. That is what this one does, the fever that rashes. This was the classic sixth disease. We don't really call it that anymore, but we could. It's also the way to remember that the bug in question is human herpes virus 6. Thinking, how do I remember that? I do not know. A rose, a half dozen roses, sixth disease, HSV 6, I don't know, something like that. Human herpes 6. Most kids are going to get this by the time their placental immunity wanes. So after about 6 months, most kids will pop up with this and have this by about 2 years of age in respiratory droplets, you see, in the same way as most. Okay, so these kids will come in because parents will come in and they will have this abrupt onset of a relatively high fever. So again, you're in the 103, 4, 5 range, and that's it. So they come in, remember that pan. So the first day they're like, I think this is a fever. Second day, really high fever. So that's right around when they call you. Third day they come in, really high fever. And you are looking this kid up head to toe. The kid is not happy because they have a fever, but you're looking for a rash somewhere. Nothing. You are looking for in the ears to see, are they red? Please, dear God, let them be red so I can give them amoxicillin and let them go. Nothing. You're looking at the eyes for conjunctivitis. You're looking in the throat. You're like, they're under 3, but maybe there's a pharyngitis. Nope. Looking for a pneumonia. Got nothing. So you're like, there's nothing. I do not know what this fever is. You let it go. You say, come back tomorrow. We'll continue to monitor this kid. After 3 to 5 days, the fever will break immediately. And as soon as the fever breaks, full body rash. Starts in the trunk, works its way out. So that's the first time we've seen that one. So trunk out to the extremities, kind of like a rose. Okay, as the rose is blooming, you have this truncal rash that spreads all the way out. That's when they get some of the URI symptoms, and then it will dissipate. Now, that's what should happen, right? So if you tell them you're going to go home and in the next day or two, because after day 3 or 4, this fever is going to break and your child is going to break out in a rash, right? When that happens, you look like a wizard, right? You look so brilliant because they're like, how did you know that was going to happen? You're like, I know that because this is 6 disease. I know exactly what's going to happen. What normally happens, and I don't want you to fall on this trap, what do you think normally happens? They come in at day 3, you've had 3 days of fever. What are you so tempted to do? So you break the fever, but what else are you so tempted to do? You're like, maybe I'm just going to look in the ears one more time. And now you've pissed the child off, so maybe they're a little bit red, and you're like, I'm just going to say they're red. Now what are you doing? Giving antibiotics. Okay? So then the next morning, when they break out in this full rash, after they've been given a dose of antibiotics, well, what do the parents immediately assume? They're allergic to it, right? And then when you come in and they're like, well, am I allergic or is it that 6th disease? How can you tell? Oh, no, you can't tell. So now you have this allergy on this kid's chart forever, when the entire time you misdiagnosed them, right? If there's not a reason to give this kid antibiotics, as much as you're tempted to do it, do not do it. I hope that you see my face being like, do not do this, when you're so tempted, when you're like, the ears are red, maybe, do not do it, do not do it. Because you end up with kids that have amoxicillin or penicillin allergies for the next 27 years, who the whole time had 6 disease, okay? So if you do a good exam, you follow this pattern, 6 disease. I'm very passionate about this one. I just realized you guys are all like, very, very passionate about it. Clinical diagnosis, you don't need anything else to do this. If you wanted to, the gold standard is a viral culture. I've never done a viral culture. I will never do a viral culture, but that is the textbook answer for how you get this diagnosis. Again, the fever that rashes, keep them comfortable, keep them hydrated, monitor them, see them every day if you need to. If they're immunocompromised, you can use an antiviral. I don't think I've ever done that, but you could if you want. And your prognosis is absolutely excellent unless they get an amoxicillin allergy for life. Varicella, let's see. How many in this room, it lessens every single semester. I realize I'm getting older and y'all are not. How many of you had chickenpox? How many of you did not have chickenpox? It's like half and half. How many of you went to a pox party?
Oh, yeah.
Yes, I too. Whenever I think of chickenpox, I think of Niagara Falls. Me and my sister had chickenpox while we were on a trip to Niagara Falls. So maybe I should go back to the adult. That's all I think about is being itchy on a boat. So varicella is your chickenpox primary versus your secondary. So varicella zoster, primary being your varicella, secondary being your shingles. We do see this still in kids. Some of the way I have seen that is that they will ask you, where does this virus hang out? So that dorsal root ganglia cell is where you will see this hide at the different dermatomes. That's why you get them out there. Respiratory again, long incubation again, and the biggest thing is one of that they will ask and parents will ask and test questions will ask is, when can my child go back to school? Your answer is when everything is crusted over, when we're not having any new crops of lesions anymore. So usually that's about a week as things are continuing to pop up. Your vaccine era, so this was, if it was 1995, oh my God, does that mean that a lot of you were born after 1995? Wow. Okay, good. That was that introduction where we saw that big change. So as that has gone down, obviously we see less chickenpox. Before we get into it, let's take an 11-minute break, and we'll start again. Stretch your legs.
I mean, I've had multiple places over time.
We can stop and see some.
It's not that big. Pretty small, pretty average. There's a lot of fences up after
The small ones.
what you got today, boys?
No, those are my two favorite combinations.
Really embracing that.
I thought the same thing, man. Been in Ohio for a year. I love the starters.
Oh man, experiencing the local culture is such a bad thing. Experiencing and adapting. Although you still adapt when you're
She's quite the, you can go back for a share.
chili. That shit is ass. Hey, don't fuck Timmy Hose, alright? Timmy Hose is solid.
Dude, you guys have steakhouse, smoke house,
What you were talking about yesterday?
cookout?
You wouldn't say that. You big bats were talking about the menu yesterday. It's not even in the state, and you're over here like, oh, dude, get this.
I'm just saying, if you had cookout, you would be just as excited. It's not my fault that Ohio has literally nothing.
No, it's false. He said they have a Wendy's. We reinvented it. He was very clear about that yesterday.
Wendy's Oh, Captain D. Ball.
I'm not talking about expanding fancy, like Chick-fil-A. Yeah, just for like fast food. Found my shirt. I don't know what I want.
You just need to. That is just what you can't drunk and I want a burger.
He's like, I don't know what I want. Like,
I was in a pool garden in my house.
See like who wants to learn.
Just the pump hose of the branch. Yeah. I mean, I'll be at his house. I'm probably the third house down from that. Who's bringing a grill? It's over by the big field right by there's a little overhang, and all there is right there is I'll look up. He's only ever been there like twice in his 10, 6 months. I'll look today. I'm pretty sure. So, might be able to like turn it.
No, it's one and done.
Because the front pad is going to be the one right
One and
cash.
done.
Okay, so it'll be burgers and dogs.
Yeah.
We'll have to get charcoal.
Yeah, I'll have it. I'm not sure if there's trail.
Well, he can do it. He's it's literally just drive right past his house. Yeah, but if it's Saturday, I mean, we'll probably show up and I probably won't stay. We have tests.
Alright. I dropped the meat from my day, so I'll see that in the morning.
Is it this one?
Like Bonbon?
It's this one.
Just show
Mine
I do that certain channel for certain things, like
Yeah.
72 Discovery, 78 like I could like go through some patterns and just these different.
I see it, but like it's not like I have like focus on it. It's not like I'm walking through like
what causes me to is vacation versus.
The covers?
It's like you're all
Still raining outside?
not really. What is the 16 like?
Okay, back into varicella. And those of you who never had the varicella, never had the pox, live to tell about it. Okay, so this time, non-specific fevers, they don't feel good, they don't want to eat, headache, pain, so not interesting at all. However, then as the rash is coming on, then the temperature will spike pretty high and then that rash will start. Usually starts on your trunk again and spreads everywhere. And when it says all lesions will be present simultaneously, all of the stages, you'll have some that are in the vesicular form, you'll have some that are in the ulcerated form, you'll have some that are in the crusted form, and some that are new and popping up throughout. So as all of the different stages are present at the same time, you're like, ah, that has to be chickenpox, has to be varicella. If a question says, they are all at the same stage at the same time, what's that? Smallpox, you should call somebody because that's very bad. You are a victim of bioterrorism, right? It's not pediatrics. Or maybe it is, but not for me. Profoundly puritic. You might hear that this, do you remember what it was called? The kind of catchphrase for this one, for varicella?
Teardrop on a rose petal.
Yeah, teardrop or a dewdrop on a rose petal. So it has this erythematous base, and it looks like there's a water drop on there at first. So that's kind of the first thing that you're looking at. Inside of that teardrop or that water drop, it will then become cloudy, and then it will ulcerate, and then it will start to crust over. So it will start, and it will then continue through that stage over and over. And as little as about 100 lesions, as many as 1,500. 1,500 lesions on a little baby, that's a lot of lesions to have. That is profoundly puritic. Goes on for about a week, usually does or does not scar. Does not scar. These are very superficial lesions, okay? Very different. You can see all the different things. So kid on the right looks happy as a clam in his little oatmeal bath. Kid on the left looks a little bit more irritated. Actually, does not look irritated. I do not think he has meningitis. Kid on the left looks a little bit more fussy. Looks like he is unhappy with the situation. Could have a few, could have a ton. So all the different things, trunk up to the face. I think this is a good picture because you can see that erythematous base. And then you can see some that have kind of that teardrop that is clear, some that are a little bit more cloudy, some that have ulcerated and opened up, and some that are starting to crust over. So, oftentimes these won't, all the other rashes, they won't make it all the way out into the hands. So if you see something that has gotten to the periphery of the extremity, that's one of those indications that you might be dealing with varicella as well. Your complications. This is where varicella gets tested. It's not interesting to talk about something that makes a kid itch. That's not interesting for pants testing. The interesting part of varicella is what will happen after. So I was in residency, I was in medical school, and I was doing a rotation out in a children's hospital, and there was a kid in the ICU who had not been vaccinated, had a primary varicella, and scratched it so bad, I think it was his leg, that he ended up with a necrotizing leg fash and ended up needing fasciotomies. And that's why he was in the PICU. All secondary to this primary varicella. So that's going to be your most common thing that you see is some type of secondary skin infection. It might be, hey, I just have a little bit of impetigo around my face because I was scratching there. It might be I had a secondary cellulitis or erysipelas, or it could be a neck fash that requires a surgical intervention. So these secondary infections are really what is going to be the primary sequelae of varicella. So things when you're looking at that, that's going to be your biggest, your most common. The thing that's going to kill the children is when you have the rare complications. So we talked about one of them yesterday with varicella. I said I'm going to ask you about it today. What type of secondary complication from yesterday do we talk about with varicella? So pneumonia is one of them because it's on the slide. Good reading. Not meningitis. Encephalitis. So varicella encephalitis can be another complication. Very, very rare, but it is one of those things. The varicella pneumonias are what often kills children. A typical presentation is it's not just the healthy individual, it's not even the standard kind of immunocompromised, it's typically children who are immunocompromised secondary to a neoplastic syndrome. So they have a leukemia, they have a lymphoma, and now they get secondary varicella and a secondary pneumonia from that. That is what kills children. So the most common is your skin infection. Most deadly is your pneumonias, your immunocompromised kids. Super, super rare is going to be your varicella encephalitis. This is also the reason that children avoid aspirin. So why we don't give aspirin is because of varicella. Back in history again, and I could not figure out how to pronounce this. He was an Australian physician, Douglas Ray or Rye. Both of them, they say you can pronounce it either way. And you're like, that's not helpful. But Ray syndrome was associated when you had varicella and aspirin given at the same time. They ended up with the syndrome that causing some liver and some CNS issues. So that right there is the reason that we do not give aspirin. So unless you are dealing with A couple of things that we'll talk about later in block 3. Don't pick aspirin for a kid. Do not pick that for this. So non-aspirin antipyretics, your Tylenols and your Motrins, your cool baths. How many of you got your oatmeal baths? I don't know why we did the oatmeal baths, but that's what we did for everybody. Seems to be the thing that's helpful. And most of the time, again, not scarring. When, for your antivirals, for your immunocompromised kiddos, we talk about acyclovir and valacyclovir. You can choose either one of those. Do you remember from farm how many times a day you have to give acyclovir? 3 to 4, usually 4 times a day for this. How many times do you give valacyclovir? Once or twice, usually twice. So if you are dealing with a squirmy, itchy child, like I'm gonna give this 4 times a day, or I'm gonna give it twice a day. So when in doubt, peds will usually choose valacyclovir for this. Who gets this? Your high-risk people. So then somebody one semester said, well, that's not helpful. I don't know who's high risk. And I said, that's fair. So here's your high-risk people. So if you are older, if you are a true adolescent, when you are getting this as a primary disease, then that is going to be at a higher risk for that. If you have underlying lung issues to begin with or immunocompromised from that, if you're using steroids, and this is really in the guidelines, it's weird to me because we still use aerolized corticosteroids for asthma, so that was one that I was not aware of. Or if you're already on a long-term salicylate therapy. It doesn't confer full immunity, so that's just one to be aware of. Kids can still get this. It's that live vaccine. So something to think about. Again, if you are immunocompromised, typically a child with leukemia or lymphoma, can be the dissemination, encephalitis, pneumonia, hepatitis. It's not pretty. Your neonatal varicellas. So this would be if you're in that right after birth and mom has primary. So this is very specific. It's not mom that has shingles. It's mom that had never had this before who's getting this and having a baby. So it's kind of backwards. We usually think in those first couple of days before and then 5 after. This is in reverse. So 5 days before, when she said, I'm positive for this, or the 2 days after, so a week long where they need to be avoiding. So this was back from block 1. This would be one of those relative contraindications to breastfeeding, would be primary maternal varicella, means no breastfeeding for the neonate for a few days. If that's the case, baby gets VZIG and immunized, or the immunoglobulin, mom gets immunized. Again, children don't go back until everything is crusted over. That's the biggest thing. If they are hospitalized, they get the negative pressure rooms because this one spreads and is highly contagious as well. They get their dose, same amount of time, separated at the year because we're trying to prevent what? Fever seizures, febrile seizures, yep, for MMRV together, and then together when they are a little bit older. Your passive immunity, you have that option for this. Do kids get zoster? Yes, they do. This is one of the questions that people will say, well, kids don't really get shingles, and you're like, you're right, it's not common, but it can and it does happen. So, pretty rare. Most of the time your guys are going to see this, and how do patients come in describing this? Yes, so they can describe it with a temperature, or it burns, or it stings. So that's very specific. If someone comes in, and they'll say it all the time, you're going to see back pain every day. Someone comes in and says, my back pain feels like it's stinging. They're like, oh, that's shingles. So specific to, they'll come in and say it burns or it stings. Dermatomal again, because it is hanging out in those dorsal root ganglia at the dermatome. The worst place is if it is going to be over the eye. You will still get that crusting, so very similar to that. For whatever reason, Ramsay-Hunt syndrome is one that people love to test. So they will look at the difference between, is it ophthalmic, so is it over the eye, or is it Ramsay-Hunt, and it is in the facial distribution, but it's the facial nerve. So distinguishing those two can sometimes be helpful. Most of the time, again, the way I've seen it tested for your pants is your secondary complications, not your shingles for kiddos. Postherpetic neuralgia, who's getting that? older or immunocompromised is typically who's going to end up with a post-traumatic matchup. So, when you guys are doing your OSCEs, that's in not next week, but 2 weeks, right? 2 weeks, and none of you are going to forget prevention. I know this class, I have a feeling none of you are going to forget your prevention. For the love of Pete, do not say things like sunscreen or seat belts. Like if you just have to pick something, give everyone a vaccine, because this could be any age group is going to need flu vaccines, and the age that you are going to need your Shingrix vaccine is how old?
50.
50. Yep, so 50 years old, you get your Shingrix vaccine for zoster. Okay, we are rounding the corner. Hand, foot, mouth. What I would write in here as well is hand, foot, mouth, butt. It is always going to be in kids, hand, foot, mouth, butt disease. Coxsackie virus. What else does Coxsackie virus cause that you might have learned with Dr. DeBoer?
Cardio something. Endocarditis.
Not endocarditis.
Pericarditis.
Pericarditis, right? The sac of the heart, Coxsackie, will cause that. Coxsackie pericarditis. In little kids, it's also going to be your cause of hand, foot, and mouth. Coxsackie. It's one that they love to test. Oral fecal. When you really think about that, oral fecal, kids are gross, right? So kids are eating their own poop or somebody else's poop, and that is how this is spreading. So if you think about that in the daycare sense, you're like, ooh, that's a place. Okay. This is one of those only ones that we've talked about today that is on the hands, the feet, and the mouth. So most places are going to spare that. What's another infectious disease that doesn't spare the hand, palms and soles? Good old syphilis, right? So if you have a toddler and you're like, well, my differential is syphilis or hand, foot, mouth, right? Just probability, it's probably going to be more than it is Coxsackie. It will also affect the diaper. And I think in most kids who have this, it almost always affects the diaper, which is why in real life, when you see hand, foot, mouth, and you're like, but it's on the butt, just think to yourself, hand, foot, mouth, butt. Okay. Very fussy, so these are painful. Has anyone had this as an adult in here? It's painful? Yeah, neuralgia. Like it's for real as an adult. If you get this, it's no bueno. We had a fellow resident who got it, who just like couldn't even move their hands. Right? It was like, I can't type my notes. Can you help me type notes? Because it just hurt so bad. Highly contagious. Sure.
Hands are
Red hand
type my
was,
notes,
it was
please.
not good. But that's what, when you really think about that, that's what's going on with these kiddos. So it's hurting them. It's hurting their mouth to drink. It's hurting to walk. It's hurting to touch things. So they're just not happy campers at all. Incredibly fussy. And most of the time what ends up happening is they refuse to eat and drink something, and they end up in this bad spiral. They're febrile, dehydrated, it's not good. So if you're thinking, how should I give some medication? What are your options here? Ooh, a suppository. What can you give with a suppository? It's pretty easy and over the counter. Tylenol, acetaminophen. So you can give acetaminophen, suppository over the counter. And that's oftentimes what you have to do with these kiddos, so that they're not in pain as much. You get them to drink something. Hands, feet, mouth. The mouth can be anywhere, so the mouth can be on the outside. You can have an exanthem, you can have an inanthem on that mucosal surface. It can be on the tongue. Can really be anywhere inside the mouth. Really anywhere around the feet, the hands, kind of those festivals that it will make. So, pain control, hydration again. The illness duration I think is really interesting. So, the kind of rule, if you guys have been around CDCs or daycares at all, is that kids can go back after they're 24 hours fever-free. They're going to let you in on a little provider secret. That's absolutely made up, right? Because they shed this virus for like 6 weeks after, right? If we said every time a kiddo has one of these things, they can't come back for 6 weeks, none of us would have jobs because everyone would be at home all the time with their sick kids. So kind of arbitrarily, as an objective point to say, well, maybe they're at least feeling better. We said 24 hours after fever. Doesn't mean they're not still contagious. So when you see one hand, foot, mouth go through, you're like, well, I know what's coming in all week because it's going to be hand, foot, mouth for the rest of the week, for the rest of the couple weeks there until it goes through everybody. You want to look like a wizard again? Here's your next thing. When they come in with hand, foot, mouth, you tell them in a few weeks, don't be surprised if their fingernails and toenails fall off. That's one of the common sequelae that you will see with hand, foot, mouth. I guarantee you, if you don't tell them this and it happens, they will be at the clinic door first thing in the morning being like, they're falling apart. Things are falling off of them, not normal, they're broken, fix them, right? If you tell them, hey, this virus is going to cause fingernails and toenails to kind of just shed off, when that happens, again, you look like a wizard. So something to think about to give for preventive education. Good old scarlet fever in that example, the numbering system, which one was that?
2.
2. Yep, exactly. Second disease. So classically second disease. What is scarlet fever? Strep. Yeah, so group A strep. If you're looking at group A strep, how are you determining if the kiddo, you're going to test them or not? What's that criteria? Centor criteria. For a kid, what is that? What is your centor criteria? Tonsil exudate, lack of cough, fever, anterior cervical lymphadenopathy, and what do you get with the extra point for on the modified score?
Age.
What's the age? Less than 15, greater than? 5. 5 to 15 to get that extra point. How do you then decide, so we've said now they have strep, how do you add and know if they have scarlet fever? Well, you have some sort of example with it. So group A strep plus a rash that starts up on the neck, so it looks like they have a turtleneck. And if you looked like sandpaper and a sunburn had a baby, that's what this rash looks like. So it looks like that and feels like that. So it really looks like a sunburn and it feels like kind of pretty fine sandpaper. So those two things together. It blanches, so you know that it is not a particular purpura. And then this one will desquamate. So one of the ones that does that. So make sense that it kind of think of it like a sunburn. It's not, but think of it like that. They will sometimes do that. I told you that you're going to have to learn a couple of doses. So Tylenol, Motrin were 2 of them, or acetaminophen, ibuprofen. The other one that I need you to know is going to be amoxicillin. The reason that we're doing this is because amoxicillin covers most things in children, but if it is going to be low dose versus high dose. So for low dose is anything that is group A strep. So you're going to see group A strep for things on the skin. You're going to see group A strep for things like this. You're going to see group A strep in different configurations. Anytime that you know it's group A strep, you're going to do this low dose amoxicillin, 50. Any other time where you're like, it might be, but it might be a whole bunch of other things, you're going to do the high dose that we'll talk about. This is our first time. You'll probably hear me say it 100 times. Your group A strep with your low dose amoxicillin. This one looks, scarlet fever, starts to look a lot like Kawasaki's, so we'll talk about that in block 3. I'm not going to pull that forward, but something to keep in mind. The differential looks kind of like that because it starts to have parts of strep, but strep plus. So you get all those strep, pharyngitis, plus this rash, plus you get some of the things with Kawasaki, like the strawberry tongue, some of those other things that you'll see. This is the sunburn meets sandpaper looking rash, and then that strawberry tongue, you see will transition where the papillae are quite pronounced. Good old herpes. We talked a little bit about that. How are we treating that if you have concerns? Acyclovir, or if you're doing outpatient and oral, more likely valacyclovir. Good. So your direct contact, the one and 2, so oral or genital. The one that I often see tested, we'll talk about if this kid had a fetal electrode during birth, fetal scalp electrode. So that's what that picture in the corner is showing you. you've ever been in birth, they're trying to monitor the baby. They will put an electrode underneath the skin of the baby's head once the amniotic sac is broken. And that is fine and it's helpful for monitoring unless mom has HSV. And as the baby is going through the birth canal, there's an open nidus of infection that leads to that HSV. So anything, when you're looking for a history on a question, if you're looking for what could have gone on in this child's birth, it will document if there was a fetal scalp electrode, and that's going to increase the chance for herpes, increase your chance that you would need to add that acyclovir. Clinical presentation can look like a whole lot of things. So they will come in saying, I have fever blisters or I have cold sores. It's going to be a herpes labialis. Your skin and mucosal surfaces are going to be involved for that one. Your gingivostomatitis is when you are doing that plus your vermilion border of the lips. So depending on where it is, still it's going to be herpes, it's just expansive or not. And then herpes bladinatorium. That one is going to be when you see that on athletes, particularly wrestlers. So if you see that in a well check or a sports physical, do you just clear the kid? Treat. So I would say you're not cleared, or you're cleared pending resolution of the herpes. Other things that it can be, if you've had a paronychia, so the skin, like a local cellulitis around the nail bed. One of the reasons that that can happen is from a herpes infection. So if you see a kid who is under 2 is typically the kid you're going to see. Kid that sucks on their thumb, sucks on their fingers, has their hands in their mouth a lot, you get that localized cellulitic infection from herpes there. Other thing that you might see is going to be if they have very foul breath and some cervical lymphadenopathy in addition to this cutaneous manifestation of this. Your treatment, we've already hit that, the cyclovirs, A or VAL. Doesn't scar as much, but can lead to some pigmentation changes, so a little bit of hyperpigmentation where you see these recurrents happen. This is one I don't normally say just write a whole bunch of refills and send them home with prophylactic doses. This is one that you should do this for kids or adults. So after a time or two, people will start to feel when something is coming on. And by the time they send a message or call you or get an appointment, it's pretty bad at that point. So after the first time you've seen them, this would be one to say, hey, here's 10 refills. As soon as you use it, refill it so that you always have it good to go at home. As soon as you start feeling that pain, start your medication. So if it's genital herpes, if it's cold sores in the mouth, on the fingers, whatever it is, we have a lot of those refills. I think that you guys learn about pinworms in every semester. I think this is one that we cover incredibly well. So tell me what you know about pinworms.
Tape test.
Scotch tape test. What's the Scotch tape test?
At night.
At night.
Put it on there.
At night or in the morning?
One in the morning.
In the morning, you take
They come
Scotch
out.
tape and you around the period anal area. What are you expecting to get? Eggs. Yep, and you have the, or well, not the eggs. So the eggs have hatched and now they are migrating out. What else do you know about it? Common infection in children. What's the symptom that they have? Itchy butt. Worse than when? Worse at night, right? So it really makes you think when you go around life and you just see like little kids just like doing this around the grocery store and everywhere else, and like you see it once as a provider now, you'll see it and you'll be like, you have pinworms. Like, or you're standing behind people in line and stuff, and you should be like, should I tell them they have lice? Like, and you think to yourself this throughout the day as you go through life. But yeah, the pinworms. Your nematodes. You guys got it. They ingest the eggs, the egg hatch, they come out in the middle of the night. Not really a serious medical issue because nothing is going anywhere other than that GI tract, but that itchy butt, that nocturnal anal pruritus. I'm not going to ask you this, the cycle of the larvae of the pinworm, but I think that it would make Major Holzberg's heart happy to know that it is here for you again as
Just
you
think about it.
relearn these nematodes. She may be gone from IPAC, but her spirit of the love of microbes will never die.
These
She's
freshmen,
going to Lieutenant Colonel.
these freshmen are like.
Nocturnal anal pruritus, what you're going to see, the Scotch tape test. Albendazole is your treatment of choice. So worms are bendy, albendazole, or any azole, nalbendazole can be your first, second line. Please treat the family. Because most of the time, if you are around a child scratches, child puts hands all over parent's face and sibling's face and everyone's face, and everybody gets it. So one of the things that people will often forget to tell families, most kids by the end of the day are pretty gross and they end up getting a nighttime bath. It can be helpful to actually do a night bath and a morning bath to get rid of some of the burden of the eggs and the larvae that are coming out. So morning baths can help, and changing all of your bed sheets, diapers, clothes, undies, to help that auto-infection risk. So you guys got it though. Scotch tape test. It will be amazing. So you will ask people to do the Scotch tape test, and they will very excitedly bring you the Scotch tape in a little bag. They will show you, they will bring it, it will be great. You will be like, that works. A lot of people don't want to use the Scotch tape directly, so I give them a tongue depressor as well. So that, hey, you would think. Contrast that to scabies. So the reason that we touch on pinworms is because the boards are trying to confuse you. Is it pinworms or is it scabies? So what do you know about scabies? It burrows. What is it? It's a mite. Correct. It's a mite that burrows under the skin into areas. So typically the fingers. In real life, where else can it burrow? Axillary, inguinal, sometimes neck. Anywhere where it can feel like it can kind of create a little bit of a cave. Okay. So eggs will go, they'll burrow in, lay the eggs, then die. So now you have a dead mite under your skin and little eggs that are continuing to poop. They hatch. You get this worst time itching at night. So these two things are distinguishing things that you're seeing this itching at night. Again, it can be anywhere where they can kind of burrow in. The difference with kids is that when you have a baby, the baby, they're not worried about burrowing in, and so anywhere that, kind of any landscape is fair for these mites. So the babies are not able to kind of itch or move, so you will see scabies that will be on face, neck, torso a little bit more. Now what happens when you give this kid a topical antibiotic? Nothing. What happens when you give this kid a steroid? What happens at first when you give him a steroid? Gets a little bit better, right? Itching helps a little bit of that inflammatory response calms down, and then what happens? Goes right back, and sometimes can be even worse. It's a little bit of a rebound effect. So if the steroids work very briefly, and then it gets worse, you're like, maybe that wasn't atopic dermatitis. Maybe this is scabies. Okay. A lot of times that will help you with your diagnosis. So it really looks like eczema, but does not respond to emollients, does not respond to steroids after that immediate, doesn't do anything with your topical antibiotics. So you will get tested for your adults with the burrowing. You'll get tested in kids then a little bit more for the way that it looks like eczema and is not. So your permethrin cream, head to toe. You do that to the entire body, but it is not effective with eggs. So you can do that all you want, and if you don't do that second treatment, it will come right back. So that second treatment is absolutely key for both the patient and everyone in the house. Heat's going to be really good against those mites. It's going to be a scabicide. So as high of heat and as hot as you can get for as much as you can get. That means stuffed animals, that means your blankets, your pillows, your pillowcases, your clothes, all of those kinds of things. The pruritus, because you had a mite that was burrowing in under the skin, that inflammatory and pruritic response is significant. And so they will often call you back after a week or so and just be like, I'm still really, really itchy. And your job is to say, is this a treatment failure? and they have new eggs and new mites? Or is this a hypersensitivity reaction because they're just still itchy from everything that's dying and resolving under the skin? So the biggest distinguishing factor is, are there new lesions? If there's no new lesions, hypersensitivity reaction. New lesions, more likely a treatment failure. Secondary bacterial infections can be common because, again, the pruritus, so very similar to your varicella. You get that secondary cellulitis. What do you know about lice? It sucks. It's true. Okay. What do you know about lice? Part of the body does it affect?
Can be everywhere.
Hair shaft can be everywhere, different types. Can it jump?
Yeah. No.
Nope. Can't jump. The lice is not going to be able to jump. So head louse, I'm not going to ask you the different names of all the different lice. That's more of a micro topic, something to be aware of. So it doesn't have wings. It can't fly. It can't jump. It needs direct contact to move. So that's one of the reasons that we see that. So transmission from fomites or transmission if someone's using the same hair ties or brushes, combs, things like that. Interesting to me, they came out with an article from American Academy of Family Physicians. So as we've kind of seen it less and less in kiddos over time, really because we shortened recess and so people aren't like playing with hair and braiding or anything. But there was a resurgence in teenagers. Why do you think there was an increase in lice in teenagers? Not sharing brushes, good thought. Not sports, good thought.
Sleepover.
Selfies. People were putting their heads together for selfies and giving lice to each other. Okay? So think about that the next time you take a selfie with someone. You want to take that risk for lice. Okay, something to think about. So head lice is going to be your most common. They are translucent eggs. So one of the distinguishing factors that you're looking at is distinguishing seborrheic dermatitis and dandruff or flaking versus lice. So lice is going to attach to that hair shaft, so if you flick the hair, it's not going to fall off. It is firmly attached. It is also translucent. And typically you will see this behind the ears and the nape of the neck. So way back in your freshman semester, when you were all doing your Clean Skills 1, you're doing your practicums and you're looking at your atraumatic normal cephalic heads, and then you're looking at the hair and the scalp and you're just like picking at each other's hair at the top. It's always real fun for me to watch. What you're actually looking for when you go to your clinical practice is you're lifting up the back of the hair because you want to see the back of the neck and behind the ears because that's where lice is going to hang out. Okay? So pawing up at the top, sure. What you're really, where the money is for making a lice diagnosis is at that nape of the neck and behind your ears. So you see the lice, you see the neck, you see the little translucent things attached to your hair shaft. Most of the time, they have done their first line treatment at home. So they have already gone home and gotten OTC permethrin, and yet there is a whole lot of resistance. So I do need you to know both of these. So know that first line treatment is your over-the-counter permethrin, that your second line treatment, if they have failed that, is either your malathion or your ivermectin. Because if they come to you and they haven't tried anything, certainly try the OTC treatment. If they come to you and they already have done that, then you need to prescribe the malathion or ivermectin. So please know both of those for testing purposes. Bed, linen, everything is going to get that hot wash treatment or placed in a bag. This is one that I'm going to let you decide how you want to do your practice. So the guidelines say if it's a brush or a comb, soak in detergent or rubbing alcohol. I always recommend to my patients, let's just start over. Let's just throw it away, buy a new brush. Okay? So up to you how you want to practice. That's what the guidelines say. Let's just throw it out. And then anything else, vacuuming thoroughly to get rid of those lice. Okay, a couple of check on learnings. We're talking about rash spreading. How does it spread from measles? Hairline, down. Okay, how does it spread for rubella? Where does it start? On the face, in the head, just not the hairline, and down. How does it start for varicella? Chest and trunk out. How does it start for roseola? Trunk out. How does it start for parvo? Cheeks, then trunk, then what? Is it itch? Yes. Parvo does itch. Yep. Which is the other one? The scarlet fever. What does the rash look like? Sandpaper, like rash, starts in the neck. It looks like a turtleneck. Okay. Who's your highest risk for parvo? Pregnant women when? Second trimester. Who else? RBC issues, like what? Spherocytosis, thalassemia, sickle cell. Correct. Okay. Who was your issues for congenital rubella? Which month? What trimester? First trimester. Correct. When is a patient no longer contagious for varicella? When can they go back to school?
After all of them have crusted.
Everything is crusted over. Good. How do you treat lice?
Cut their hair
Short
off.
term, cut their shave their head. No. Permethrin is first, second,
Ivermectin.
malathion, or ivermectin. Yep. Anybody else itchy?
Yeah.
Itchy. Okay. Where are we? Oh, should we start the other one? Okay. Do you need a 5-minute stretch break?
Sure.
What do you say? Nope, he says no. No breaks for you.
Also for you.
You have a Seinfeld. Okay, I do.
Dad.
Do you guys like morning lectures better?
Yeah. Looks like a bunch of them.
We're still probably gonna cut a little bit early and then take some of lunch, because I have a meeting at 12. Okay. Switcheroo into heat. This one is a long lecture, so we will do some of it today, we'll go into tomorrow. This is so high yield for real life. So yes, there's some testing stuff in here, there's really not that many objectives. So the length of it for the amount of objectives, a little bit of a mismatch, but this is what you're gonna see in ERs, urgent cares, primary care, on your rotations. This is really where it's at. So a little bit of life meets pants for some of this. All of your objectives, there's a million things, there's a lot. Okay, so we're gonna go through each of the things. We already talked about head really a lot in block 1. So you had the fontanelles and the craniosynostosis, and the macrocephaly, so head already aside. So we're jumping into the eyeballs. Not gonna go over anatomy again, that was from freshman and then sophomore with heat, but if you haven't thought about it in a while at all, you haven't thought about the eye in a couple semesters and need a review, that is in there for you. Things that we need to talk about. The difference between optometry and ophthalmology. So, sounds like an elementary discussion. It gets missed all of the time. So, an optometrist, separate school. They do medical. So they are, when you think of in the medical world, they're like your internal medicine doctors, but for the eye. So they are not doing surgical issues at all. That is for ophthalmology. Ophthalmology would be in the medical world, like your general surgeon. So they are going to do the surgery of the eye. The unfortunate part, in some ways, is that in optometry school, they don't get much training, if any, on children. Ophthalmology does. So, very tricky to decide when am I sending this kid to optometry for a medical issue versus when am I sending this kid to the ophthalmologist for a surgical or a medical indication under 3. If you have a child with any eye thing really under the age of 3, they are gonna go to ophthalmology. They're the only ones that have training in those kiddos. You need glasses for a kid, you need some medical attention for a kiddo or a teenager and older, optometry is just fine. So I'm trying to make those distinctions of when you are going to do optometry versus ophthalmology. Big takeaway, under the age of 3, always gonna go to ophthalmology. Baby comes out. This is from block 1 again. Baby comes out, they've been in a dark environment for 9 months, really not using their eyes at all. So they come out and they're legally blind little creatures, right? Their vision 2200 to 2400, legally blind. They can see some light, they can see some faces, that's about it, what they're doing. Other thing is that when they're crying, when they're using that increased state of arousal to let you know something's going on, for the first few months, up to 1 to 3 months, they're not even producing tears. So they're just crying, nothing's coming out. So again, just that state of arousal. So the tear ducts and the tear system and factory really isn't working, isn't primed for those first few weeks out of utero. Those infants, again, they see mom's face, they see some light, as a feeding and a bonding mechanism, that's about it. By the time they're 2 weeks old, that's really about all that's happened, maybe a little bit of sustained on some faces for a little bit longer. And it's really by the age of 2 months that you really see babies that are starting to track with both eyes. Still okay for them to have those googly eyes, the dysconjugate gaze, up until 4 months. They come in, the 2-week visit, parents are freaked out that the eyes are going this way, totally normal. They come in for 2 months, parents are freaked out now the eyes are that way, still okay. Once they're coming in 4, 6, 9 months, the eyes are still doing that, not okay anymore. So those ones, again, they're under 3 years old, so they're gonna go to ophthalmology. They're worried about strabismus, which we'll talk all about. Everybody gets that red reflex checked. If it's not, what is that called again? Leukocoria. We're worried about retinoblastoma. We just talked about one of the things that causes cataract. Which of those viruses from the last lecture caused cataracts? Congenital rubella, correct. What else does congenital rubella cause? PDA, what else? Deafness, what else? What's on the skin? The blueberry muffin baby. Yep, extramedullary hematosis. Okay, back to, I don't know how we got to blueberry muffin problem. There we go. But okay, so your basic eye exam for all kiddos. You come in, and when we do this for lab next week, we're going to make sure that every kid has a red reflex. We're also going to just use your visual inspection. Do the eyes look symmetric? Are they dysconjugate? Are they out here? So are they in alignment? Are the pupils normal, and are they constricting and dilating? And are the eyelids and the eye structures symmetric? Are the eyelids normal? Is there any ptosis? So it's a very, very quick exam. You're looking at these kids visually, you're looking at their pupils and a red reflex. So really a basic exam on a kid should take 30 seconds, not very long. Your visual acuity then, you can go all the way down to 6 months. By the time if you're using a Snellen chart, they need to be able to read. So typically about 5. I'm gonna be honest, in real life, couldn't tell you the last time I used a Snellen chart, because why would I do that if I could just use the visual acuity check and it will tell me exactly what the prescription is. So, you don't need to read, but other things you can do. So, you really don't see normal vision until kids are over the age of 6. So they might have crisper vision and normal vision before then, but I don't expect that to be the normal range until into those school age years. So again, we have to go from 2200, 2400, legally blind, up to normal vision by the time they are school ready. So what's going on during that period of time? The most common thing that is a reason for visual impairment was that retinopathy of prematurity. So again, if you are taking a test and you're thinking, why do they have visual impairment? And I tell you that they were born at term, please do not pick retinopathy of prematurity. They were not premature. So we'll give you those adjectives, I'll give you those clues. Don't pick retinopathy of prematurity if they were term. even though it's the most common. So how do I determine where along that spectrum from legally blind to 20/20, how do I know what's normal in that? The easiest way to do that is the rule of eighths. So you take their age in years, so their age plus what equals 8. And that's where their vision should be. So a 2-year-old comes in, you take their vision, and it says their vision's 20/60. And you're like, 20/60? And you're like, 2 plus 6 equals 8. That's normal for that 2-year-old. They come in, 3, they should be 20/50, 4, 20/40, 5, 20/30, 6, now at 20/20. The rule of eighths is how you're going to know, are you normal or not? So let's say a 4-year-old comes in. 4-year-old comes in and they are 20/50. What do you do with that kid?
Observe.
4-year-old comes in, they're 20/50.
Send them to.
That child I would send. Why? Yeah, because they're not at that baseline where you would expect them to be. The other thing that you would send them for is if they are more than one line difference. So let's say a 4-year-old, or let's say a 5-year-old comes in, one eye's 20/30, or even one eye's 20/20, and one eye's 20/50. Big difference, that's when I send them. So anything more than one difference, or anything below what they should be for their age would be a referral to have a full ophthalmic evaluation. As a reminder, hyperopia versus myopia. So farsighted, I can see things far, I can't see them close. Myopia, I can see things close, I can't see things far. In life, what does this present like? This is kids that hate school for one reason or another. So your farsighted kiddos, they see far things, so they love PE, they love doing things that are out and active, they really, really hate reading. You have your kids then who can read and can't see anything out there and hate everything else. Any type of school evaluation, any type of ADHD evaluation should include a visual acuity because half the time they just can't see. So they hate it because they can't see it, which makes sense. Like if you couldn't see it, maybe you hate eye contact anyway, I don't know. But if you couldn't see it, you'd probably hate it too. So first part of school evaluation, can you see things? Is that why this is going on? Amblyopia and strabismus. It really should be strabismus and amblyopia because strabismus is talking about the eye itself. Amblyopia is talking about the secondary brain. So what is the brain trying to do? So if your brain is trying to look out at an object, it's trying to take one picture of an eye, get a duplicate picture with that second eye, and make a 3D image. So it'll go back to your optic chiasm, it will switch upside down and switch back, and your brain will put together a 3D picture. It's what it wants to do every time. It's how we have depth perception, it's how we can make sure that we have a good peripheral vision and a nice 3D picture. If that doesn't happen for kids, the brain will start to just shut down and it will work off of one picture. So that's sort of what's happening with strabismus and amblyopia. So strabismus, what lay people will call it what? The lazy eye, right? And you want to prevent that for kids because there's a big social stigma in that. If you're looking at somebody and you're like, I don't know which eye to look at. Which one's the good one, which one's the bad one? We don't want that for kids as much as possible because we can help prevent that. So that's why your basic exam is looking, are those eyes aligned? Are they moving together? Are they doing what they want to do? Because they're under the age of 8, so 8's a big eye number. So the rule of 8s and up to the age of 8. Up to about the age of 8, you can retrain that brain. And things that have shut down can kind of come back to life and prevent amblyopia. After that, not as much. Okay, so when you're looking at strabismus, we have to name it. So we're naming for the affected eye. So if it's going into the nose for this kiddo, it's an ESO. If it's going out, it's an exo. If it's going up, it's a hyper. If it is all the time, it's going to be a tropia. If it is just some of the time, it's a phoria. So phoria means phased, so it's just a phase. So it comes and goes. Tropia is going to be all the time. So that's going to be important to be, is it left or right? Eso, exo, hyper, and then tropia or phoria when you're naming these things. So ophthalmology, if you're like, I don't know, eye looks weird, ophthalmology doesn't really like that as much. Give them a good definition of what's going on. Strabismus then, so okay, your visual acuity is misaligned. Now your brain is starting to shut off. A couple of reasons why that is happening. So the first one is going to be a strabismus. So the brain cannot get a duplicate image. So it says, I forget this one. I'm just going to shut that one off, and I will continue to only take this one. This eye and the brain not being used starts to just drift in or out. Typically out, it's going to do that. So a high strabismus will shut off part of that brain, amblyopia. Second thing would be your high refractive errors. So a hyperopia, myopia, where the kid really just can't see, that brain just starts to shut down. And then the thing that we worry about, I think I worry about the most outside of strabismus, is going to be your deprivation. So something is not allowing this kid to see something. So maybe that's a ptosis of the eyelid. Maybe that's a large capillary hemangioma where they can't see. Maybe they have that infantile cataracts, glaucoma, retinoblastoma, retinopathy of prematurity. So any of those things where the eye isn't getting that visual input is going to be your deprivation. So first thing for alignment. Haven't thought about the Hirschberg test in a while, have you? Or the corneal light reflex test? You were thinking about it yesterday? I know, you were reading in preparation for today. I love that. I love you guys do that. Thanks so much for lying to me. This is going to assess your alignment. So you put this light up. So it's a very simple test. You put the light up and you see, is that light in the middle of the pupil? It would be slightly medial, but is it in the middle of the pupil, yes or no? It's all you're looking for. So is it right in the middle? Yes. Is it not? Then no. There's a particular entity. I think I've seen pseudostrabismus on every pants exam. So pseudostrabismus is one of the ones that they'll try to catch you on. Because it looks like this kid has misaligned eyes, but the light reflex is normal. So you're like, what's going on, right? If you look at a baby, babies have a lot of extra on their face. They have a pretty wide nasal bridge. There's a lot of extra pudginess. There's large epicanthal folds. And so they really haven't grown into their face yet. So you're looking at them and you're like, eyes are kind of off. But you put that light reflex there, bam, right in the middle of those pupils. So normal light reflex, but looks like strabismus, it's a pseudostrabismus. Nothing's wrong with the eyes, and you can't tell the family something's wrong with their face. Something's wrong with their face. They just haven't really grown into their face. Let's take a picture, look at what that looks like. Super cute kid, right? So if you look at it, she has a pretty wide nasal bridge. You could fit an eyeball in there. She's got extra pudgy that she's got going on, these large epicanthal folds. So it looks like that left eye is an esotropia. But when you look at the way that that light reflex hits, it's right in the center of both pupils. So not strabismic at all. This is just pseudostrabismus. So when you're looking at that, and we're trying to determine that, right where that little white dot is what's going to help you. So and I promise you, the board exams and my exams, they're not going to try to trick you. They're really not. They're like, it'll either be in the center or it's not in the center at all. It's not like, well, let me get a protractor out and look like, no, it's not going to be like that, right? So if they're in the center, normal light reflex. If it's really outside of that, lateral, it would be an ESO, medial, exo, or hyper. Your special ocular tests, you guys thought about these in a little while? Probably been a little while. So your cover, uncover, your cover test, and then your cover, uncover test. Okay, so let's go through this. So let's say my right eye is my bad eye. It actually really is in real life. Okay. This one, most of the time your cover test is looking at your tropias. So it's all the time and you're confirming this. You can do it for the phorias too, but most of the time it's going to be your tropias, okay? So what happens, remember my right eye is my bad eye. What if I cover my bad eye? What happens to my good eye? Absolutely nothing. I cover my good eye. What happens? This one focuses, right? That actually does. It's like, okay. So that's what you have to think about the eye. the lazy eye that normally has this one to compensate, once you cover the good eye, it snaps into place. It's like, okay, fine, I'll do something. So you see that most of the time with the tropias. So that's how you can tell, yep, it's that side that's the tropia because it snapped into place when you covered it. What about the forias? So again, right eye is the bad eye, but I'm looking straight at you, my corneal light reflex is normal. What happens when I cover my good eye?
Goes to yes.
Nothing, right? It's still holding strong. It's like I still got this, I'm holding on, I'm good to go because it's a foria. So I cover my good eye, nothing happens. What happens when I cover that bad eye?
Drifts off. It's moving underneath the cover.
It's moving underneath the cover, so it's like, oh, thank God, I can relax. And then you take it away, you uncover, and now it snaps back into place. It's like they're gonna find me out. Okay? So cover, uncover, good for forias. So when parents come in and they say, I swear when they get really tired or right before a nap, I swear this one eye just drifts, but you can't tell, and you're like, which eye is it? And you're like, I don't know, left or right. They will say that. You're like, I don't know. The cover uncover test is helpful for those forias to see what's happening. So reminder, cover the good eye for a cover test, nothing happens. Cover the good eye, the bad eye snaps into place. When you do the cover uncover, you cover the bad eye, it drifts and comes back. So always, this one's one of my favorites on the test because you guys will sit there and be like, it's really fun to watch. So I always look forward to that on this test. Cover test. So which is his affected eye? How would you describe that? You did this cover uncover test. You're calling ophthalmology. You say this little kid has what? Which eye? Left. Exotropia. Okay, so other times you're going to call. So the esotropia. A lot of times this can be congenital. In general, most of the time they get to about 2 before this really pops up. So congenital, obviously they're going to go to ophthalmology right away for some surgical corrections. For both ESO and EXO, most of the time they're 2 to, in that toddler years, 2 to 5. Most of the time they'll get some refractive help, some glasses, patching, we'll talk about in a second. If they've been totally fine, so they weren't born with this, it didn't come on when they were 2, 3, 4, and now they're 5, and all of a sudden, out of nowhere, when their vision is supposed to be crisping up almost to perfect, now they're starting to have a drifting eye, that is a tumor until proven otherwise. Something you're worried is pushing on that part of the eye and forcing it to drift. So late onset tropias, particularly esotropias, brain tumor until proven otherwise. Okay? Normal toddler, normal strabismus, send them to ophthalmology. Late onset, tumor, bad news bears. So for your patching, for your correction, for your surgery, are you patching or good eye or bad eye?
Good eye.
You're patching the good eye. You're forcing that bad eye to work. How long do you need to patch during the day? How long every day do you need to patch?
8 hours.
Who says more than 8 hours? Who says less than 8 hours? Who says more than 4 hours? Who says less than 4 hours? So less than 4 hours wins. You only need an hour a day. That's why kids are amazing. They're so cool. You give them a patching for 1 hour and their brain's like, oh, I got it. Kids are amazing. It's so cool. When I was in residency, we used to try to patch all day. So we're like forcing these glasses on these kids and like trying to like make them pirates all day. And we're like, let's just do this for an hour. The other option you can do for the kids that are like, nope, not doing it, is to put atropine in the good eye. So it will end up dilating that good eye and force the bad eye. So sometimes they will use with drops. If that doesn't work, then they'll do surgical corrections. If you get to your phase 2 rotation and there's PEDS ophthalmology there, those cases are super fun to scrub into because it's like watching, like they're like working on little mice, like the smallest little tools, and strabismus surgeries are just kind of cool. So either way, ophthalmology will help you. Again, your red reflex, I cannot stress this enough. You do not have a normal red reflex ophthalmology until otherwise proven. So something's going on with that kid that is never normal to have. Make sure that you get them to the appropriate treatments. I don't know why. It's the same thing. Red reflex, not normal syndrome. Okay, so who gets this complete examination for ophthalmology? So I need a complete examination if they've had a premature birth. And what I mean that is usually less than that 32 weeks where their full retina is not vascularized. So retinopathy of prematurity, they're automatically going to go. So why does this matter to you guys? You're like, I'm not going to be in the NICU, I'm not going to do this. PCS is all the time. So someone PCS is there, your job to make sure, hey, they got here, maybe they're a year now, maybe 2 years now, that they were significantly premature, they still need to continue to follow with ophthalmology. So getting them to that right specialist. History of cerebral palsy or Down syndrome. Do you remember what happened in T21? What did those kids have? A couple of things that they got. They have 3 copies of something. 21. What did they get early? Early cataracts. Beta amyloid plaques. So those early cataracts for those kiddos. So T21. They also had those brush field spots. Whoa, it's coming back. I see it. I see the lights. Okay. And then any school, poor school performance. It's the first part of that evaluation. What else besides a visual test? Hearing evaluation. Good. Anytime then ophthalmology, so any new nystagmus or any nystagmus that's never been evaluated, so nystagmus in a kid, not normal, need to go see. Any of your strabismus, and then again, if they're not on their normal line, that will equal 8, or if there's more than that 2 difference, they need to go as well because they are also at risk for amblyopia. And red reflex, probably 100 times. Do you want to stop, or do you want to go a little bit more? You're just dead inside? Okay. Conjunctivitis. What are the different types of conjunctivitis? Viral, bacterial, what else? Viral, bacterial. Allergic. One more. I guess only 2 more. Fungal, pretty rare. A chemical. A chemical conjunctivitis. And we'll add one more because it's PEDS, neonatal conjunctivitis. Most of the time, you're going to be your viral or your bacterial. It's going to be pretty soon. Your conjunctiva are going to be red, so that's one of the things that you will always see is a lot of times people, the conjunctiva will not be red, and they'll be like, oh, it's down in, it's scleral. Anyway, doesn't matter. But conjunctiva have to be red. Discharge from the eyes. Things that you will see that will be going on, oftentimes, in babies particularly, it will be a nasolacrimal duct dysfunction. We'll talk specifically about that after lunch. Maybe this baby has some sinus disease going on, some otitis media that has spread, and then certainly allergic. So if you need a refresher on the different parts of your eye and where that is going to be. The one thing I want to point you to is the follicles. So bumps like over here in the area of in question, you can see some of the cobblestoning or some of the blebbing in there. So things to look for. That's why we always will have people pull down their eyes. So if they're pulling down their eyes and you still can't see, you just had them pull down their eyes for nothing. Okay, so you have to be able to actually see the follicles. So your conjunctivitis, looking at that, oh, it makes my eyes water to look at. I don't even know if you guys do, but when you're looking at that, most of these are limbic sparing. The classes a couple of times ago were like, it's been a little while since we've heard of the limbus. Where's that limbus? That's the limbus. So right around the edge of the iris is typically spared in kids. So we'll talk about limbic sparing conjunctivitis versus non-limbic sparing. Most of the time in kiddos, it's limbic sparing. So because it's PEDS, we always add in that neonatal type of conjunctivitis. We'll talk about those particular kinds. We'll talk in detail about the infectious type, allergic, and then briefly on chemical. So when you're thinking of neonatal conjunctivitis, in block 1, we use silver nitrate to cauterize something. Do you remember what we cauterized with silver nitrate? Yeah, the belly button, your umbilical granulomas, right? So that was getting rid of a granuloma. So what do you think it happens if you put silver nitrate cautery in the eye? It ain't good. It's gonna cause a burn into that eye. What places used to do, before erythromycin, if they thought that there was concern for a conjunctivitis at birth or mom had something, they would use silver nitrate to burn the eye. And they're thinking, well, that maybe got rid of the infection, but we caused a neonatal chemical conjunctivitis. So some places in the world will still use that. You might see a chemical burn from a silver nitrate. Very, very, very rarely, I've never seen it, but it's in the textbook, you could get an erythromycin reaction to that. Then they will give you specific days. So I don't want you to worry about the days as much as in real life. If they come in at that 2-day visit, think gonorrhea. They come in for their 2-week visit, think chlamydia. So the days will overlap, there will be something, but right away, and a lot of purulent discharge is gonorrhea. Several weeks into it, scant, watery, but you can't get your hand around what's going on, chlamydia. If ever a dendritic lesion, that's going to be your herpes. So any test that I've ever seen, they will give you this picture, they will give you a dendritic lesion. If that's the case, and you know that you have herpes somewhere in this baby, who's a neonate, where do they go?
Ophthalmology.
Not just ophthalmology, where else? When in doubt. Not peds. Thank you. You call me and I say, this baby, this neonate, has concern for HSV. Where do you think we should send them? Not infectious disease. To the ER. To the ER. This kid is concerned for a neonatal sepsis workup. Okay? You see this? Neonatal sepsis workup. Any HSV in the neonates, I'm going to get the full thing. They are getting acyclovir. They are getting a whole gambit of things because neonatal HSV in any form or fashion, no bueno. Okay? Then a few days later, they come in for their 2-week visit. Then that's when I think about your chlamydia. Okay? Reminder that erythromycin does nothing for your chlamydia. Oh, not your chlamydia, for chlamydia. But it does, erythromycin is for the gonococcal prevention of blindness. So you have this neonatal conjunctivitis, they're going to ophthalmology, but you're going to treat empirically if they have neonatal conjunctivitis. So this one gets real weird because it depends on what it is. So for gonorrhea, happens right away. We're using erythromycin to prevent it, but if it comes, then they typically have copious amounts of drainage. So they not only need IV antibiotics, they have to be admitted for this because the irrigation is so significant that the babies can get unstable from the amount of irrigation. So they're doing these pretty intense eye irrigations. So babies end up hypothermic, not wanting to eat. It's a whole thing. So they end up getting admitted for that. So gonorrhea, super early, super serious, ceftriaxone, admission, the whole thing. Chlamydia, a couple weeks in, they're like, that's not quite normal, and that's just PO medication. So it's PO erythromycin. We don't use that a lot. We don't use PO erythromycin a lot. This is one of your only times. So don't start picking it for everything. This would be the time. So erythromycin PO for babies with chlamydia, neonatal. Chlamydia, neonatal conjunctivitis. Pseudomonas, pretty uncommon between gentamicin, not something that we see all that much. HSV is always going to be your IV acyclovir anytime, so that's back into serious mode. So gonorrhea or HSV, the whole thing. And then Staph aureus is the opposite, topical antibiotics. So it's a little bit all over the place. So some get PO, some get topical, some get IV. So make sure you can identify which one you're seeing and then what kind of treatment they're going to need. I think 1140 is a good do you mind if we start at 12:40? That time to still give an hour to the meeting. 12:40. See you guys in an hour.